Hello everyone. Today we will be discussing infantile hypertrophic pyloric stenosis. Okay, this is an important topic. So, age predisposition, it is mostly seen in 2 to 8 weeks of age with peak at 3 to 5 weeks, and then it is rare after 13 weeks age. Fine. So, male to female ratio is 4:1, and one important thing to note that firstborn is male frequently. Okay, so incidence is 1 in 300 to 900 live births. Then the highest incidence that is seen in Scandinavian population, and lowest risk that is seen in China, Chinese, and African Americans. Okay, presentation. So it presents as non-villous projectile vomiting with post emesis or vomiting hunger, and then the patient do not look sick. So this is how you can differentiate this from sepsis. Okay, so this is one differentiating feature between sepsis and infantile hypertrophic pyloric stenosis. Okay, on examination, there is visible peristalsis, and it is from left to right, whereas right to left peristalsis that is seen in colon obstruction, transverse colon obstruction, and step ladder pattern that is seen in small bowel obstruction. Okay, then on palpation, olive shaped mass that is seen in epigastrium. So olive shaped mass that is felt in epigastrium. Okay, there are some anomalies associated with infantile hypertrophic pyloric stenosis. We have malrotation, anorectal malformation, we have undescended testis, we have hypospadiasis, then we have Hirschsprung disease, then we have inguinal hernia, then tracheoesophageal fistula, then esophageal atresia, and then we have axomphalos. Okay. One thing I want to tell here that about this vomiting. So vomiting, which was non-villous and projectile. So this vomiting, it is progressive with the duration. So it is like it progresses to the state when there is vomiting after every meal. So this is important, vomiting after every meal. And then it does not waxes and wanes. And this is how you can differentiate this IHPS from gastroesophageal reflux and pylorospasm, in which we have waxing and waning of this state of vomiting. Okay. Then an investigation, first is ultrasonography, in which we can see there is thickness of pyloric muscle, and so it is more than 3.5 mm in prematures and more than 4 mm in others. But most of the books it is written more than 3 mm. Okay, so let us take more than 3 mm here. Then there is second point, there is length of pyloric channel that is more than 16 mm, and some people they consider diameter also, that is pyloric diameter of more than 14 mm as diagnostic. So one thing to note here that there is limited or no passage of the feed through the pyloric channel, but this is not the diagnostic sign. Okay. Then we have next investigation, that is barium meal. Barium meal. So we have many signs important in barium meal. So first, so look at this diagram. So first thing is double or triple track sign. Look at this. So double or triple track sign. Double or triple track sign. So this is because of crowding of mucosal folds in pyloric channel. Okay. Then we have string sign. String sign. String sign. So this is passage of small streak of barium through pyloric canal. Okay. So then we have this diamond sign. So this is basically a transient triangular tent like a cleft in the mid portion of pyloric canal, and with the apex pointing inferiorly. So this is apex, it is pointing inferiorly due to mucosal bulge between two separated hypertrophic muscle bundles on the greater curvature side within the pyloric channel. So this is diamond sign. Then we have teat sign. So this is teat sign. So this is basically out poaching along the lesser curvature due to disruption of antral peristalsis. Okay, antral peristalsis. Then we have beak sign. So this is beak sign. And beak sign is due to a mass impression upon antrum with streak of barium pointing into the pyloric channel. So this is beak sign. Okay. Then we have mushroom sign. So this thing is mushroom sign. And it is due to indentation of base of duodenal bulb. So these all were the signs in barium meal of infantile hypertrophic pyloric stenosis. Fine. Now we have biochemical picture here. So this biochemical picture shows hypochloremic, hyponatremic, hypokalemic, metabolic alkalosis with paradoxical aciduria with secondary respiratory acidosis. So this is electrolyte imbalance in these patients. Management is basically first thing is to keep these patients nil per oral and to aspirate content, and then along with this IV fluids and electrolyte correction. So it may be corrected with 0.9% saline with 0.15% potassium chloride in 5% glucose given at the rate of 6 to 7.5 ml per kilogram per hour, which corrects the abnormality and provides maintenance to the baby. Okay. So as the chloride deficit is replaced, so kidney corrects the pH, and so the pH becomes normal. So in these patients, so we straight away we go for ABG on presentation only. Fine. Some people say that there should not be prolonged nasogastric aspiration, so it will lead to further electrolyte imbalance and further deterioration of the patient. Fine. So after that, we have how you manage it surgical. Surgical procedure is Ramstead threaded pyloromyotomy. So this can be done via open technique or it can be done by laparoscopic. And open is basically mini laparotomy. So this is Ramstead threaded pyloromyotomy. So this is image showing pathology and management. So this is basically there is a hypertrophy of muscle fibra pylorus. So this is hypertrophy of muscle fibers pylorus. So what we are doing, so we are dividing the muscle fibers. So we are dividing the muscle fiber in this image using scalpel. After that we mobilize the muscle fiber using the pyloric spreader. So this is mobilization of muscle fiber. So ultimately what is seen, there is whitish color mucosa which pops out. So this is seen. So this is the cross section before myotomy and this is cross section after myotomy showing the bulging of mucosa. Fine. So whenever if there is any perforation in the mucosa, so it is closed by horizontal mattress suture. Fine. So this is Ramstead threaded pyloromyotomy. Feeding after surgery, that is resumed within 24 hours. And this vomiting usually resolves after 12 hours. What are the complications now? Complications of surgery. So one thing is incomplete myotomy. Okay. Second thing is perforation. Then perforation of mucosa. Third thing is wound infection, surgical site infection. Then dehiscence. And then hemorrhage. And if there is perforation, then we have to delay feeding up till 48 hours. So if there is perforation of mucosa which you have repaired, you have to delay feeding up till 48 hours. So one more procedure is there, that is double Y or Elliott's pyloromyotomy. One more thing I want to discuss here, genetic mutation which is also associated with infantile hypertrophic pyloric stenosis. This is 11q14 to 22 and xq23.